Hi, I'm Jack West, medical oncologist at Swedish Cancer Institute in Seattle, Washington, and the founder and CEO of GRACE, a global resource for advancing cancer education. I wanted to talk briefly about the common setting of locally advanced non-small cell lung cancer and how we optimally manage patients who present with this particular setting. Now, non-small cell lung cancer is the more common subtype of lung cancer that we see, accounting for about 85% or more of the lung cancer in the United States today. And locally advanced disease is typically what we would consider stage 3 disease out of 4. And that means that the disease is extensive enough within the chest that surgery is generally not a straightforward approach and typically not recommended. It is recommended for a minority of patients with stage 3 disease. But the cancer also has not spread elsewhere in the body. And this is a setting in which it's important to distinguish that we can treat most of the patients with curative intent. What that means is that sometimes the treatment may be challenging to administer and to deliver, but there is the potential prize at the end that if patients can get through it, it could be worth the side effects, the rigor of treatment, because that could mean that patients are completely cured and can live for years and decades after that. Now, what is the optimal treatment? Well, historically, what was done back in the 80s and into the early 90s was radiation alone, and that cured a minority of patients, but really not nearly enough. The next generation of trials looked at adding chemotherapy, typically given before the radiation, and showed that the patients who got chemotherapy followed by radiation did have a better chance of being cured than the ones who just got the radiation alone. The next set of trials that were done, and this is largely over the last 10 to 12 or 15 years, have looked at the different ways to combine chemo and radiation. One group of patients getting sequential chemo and radiation that did not overlap, and the other group of patients getting concurrent chemo and radiation over typically about 6 to 7 weeks. The concurrent approach is a more challenging one in that there are more patients who have difficulty with esophagitis, inflammation, essentially a burn from the radiation combined with chemotherapy in the esophagus that can make swallowing difficult, as well as a higher risk of pneumonitis, which is inflammation of the lungs that occurs typically in the months right after the completion of that treatment. But despite the challenges of that treatment, there were more patients who went on to not have evidence of that cancer growing and who were alive 3, 4, 5 years later. And so this combination of chemo and radiation given together has really emerged as the optimal approach for patients who can tolerate it. It is still a challenging approach, and even in the clinical trials where we try to be extremely careful monitoring patients and have expert physicians often doing this treatment, you do see a minority of patients, typically around 5% or so, who actually die from the treatment. And so we recognize that and have a healthy respect for the challenge of the treatment. But if that delivers more patients through all of this with no evidence of their cancer, it is arguably worth it as long as a patient is fit enough to tolerate the challenges of that treatment. It does require patients to be followed closely. It also requires good support for patients. Some patients are going to need extra fluids, everything, all sorts of things. But that is the current standard of care for patients who are fit enough to pursue that approach.